This is now a very different topic, and we talk about foraminectomy. And since I have not done this microsurgically, I will show you only endoscopic images, which I think is no problem because the technique is absolutely the same. So we talk about the approach to the posterior neuroforamen for decompression of the nerve root. And this is a very old procedure. Has been described many times, and it's a very easy procedure. I think if you have a good bone effusion and just radicular symptoms on one side or both sides, and then a degenerative spine, I think it's worth to consider this foraminectomy for decompression of nerves. So we rather do this in such a condition. You can also do this with the disc prolapse. I don't know if the results are as good. This is a matter of discussion. I personally prefer rather the anterior approach if you have a disc prolapse, because there's no way when you do a posterior foraminectomy, you have at least to harvest a little bit, maybe 1/4 of the facet. So then you take out the disc and you sacrifice part of the facet. And you have so terrific results with the anterior cervical ACDF, I think. Well, in our hands, we rather prefer the ACDF. So what are the advantages? You don't have any exposure of the anterior structures. You have a much better exposure of the nerve. I think it's just wonderful to see the nerve from posterior, much easier than from anterior. And of course, you have better access to any structure in the neuroforamen, particularly if they are posterior to the nerve. What are the disadvantages? Well, anything which is anterior to the nerve is difficult to decompress. Also, you have to deal with a congested vein, so you have really some risk of venous bleeding, which is sometimes, well, quite difficult. So we did a couple of these procedures in the semi-sitting position, actually, which I think is very nice. The disadvantage is that it might occur that you have a venous air embolism, and it's more difficult to treat this and to notice this than in a traditional semi-sitting position, because in the cervical, just the pressure on the jugular veins will not show you the open vein in many cases. So you have to have some more experience. If you don't have experience with the semi-sitting, or you let unexperienced people do it, I think rather a flat position is preferable. You have some neck pain, particularly in the larger posterior approaches. I think pain is an issue. While in the anterior cervical, pain is no issue. I think they have some swelling problem for a week, and that's it. Posterior approach, pain is an issue. So I think this, if you do this posteriorly, I think at least you should use a tube system, so to have a minimum muscle trauma. Well, as I said, you have to deal with the facet joint to some degree, and it's always said that there's a risk of spinal instability. Well, a significant instability just doing one level, one side nerve decompression with a posterior foraminectomy, I think, is not an issue. I've never seen that. So there's some papers out there. What is the reason for minimally invasive technique? I think I just go over this because it's not in the focus here. But there's basically not really any data which favor the minimally invasive or procedure over the other, except for post-op pain and in hospital stay. So here, this is the conclusion of the second meta-analysis. Both can be treated with the cervical radiculopathy, can be treated with both methods, so open and minimally invasive. There's no significant difference between those two groups. But there are some advantages, particularly if you really do this small down. You have a high do this with a small approach. You have a high magnification with an endoscope, and you have a beautiful visualization. You can reduce the approach, the trauma of the approach, and if you have this, ideally with an endoscope, you have a completely new technique. This is only the case in the endoscopic third ventriculostomy. I don't know any real endoscopic procedure in the spine you cannot achieve with an open approach. Well, we have to have in mind that we can treat all this with an endoscope, but we need sufficient decompression. So I think one of the big advantages is that you have a very high magnification and better illumination. This is an example for pituitary surgery, but this is the same we have in the posterior cervical, right? You have a microscope and a lot of light, but basically at the bottom of the surgical field, only a small fraction of all your image of all your light is seen. So with an endoscope, although the resolution is much less, you have a much better exposure, much better illumination of the area. And this turns out, we did a study with 10 neurosurgeons, surgical residents in 10 patients, and it turns out that using the endoscope, they recognized significantly more structures in the spine than with the same tube and the microscope. So it's the endoscope, the magnification and the good contrast with the high definition technique gives you better results. Okay, back now to endoscopic cervical foraminotomy. There are just two papers on this. I don't want to focus on this. Now we go for the surgical technique. I think it's all, again, very important is positioning. And if you don't know exactly which level you're gonna, or you cannot expose the level you want to do surgery on, this is a difficult thing. So for example, frequently see 6, 7, 7, 1, and you don't see exactly, you have no exposure of the level at the X-ray. That's difficult. Particularly if the bony stenosis, you never really are sure that this is the right level. So what we do this, then CAT scan navigated. It's a big advantage. If you don't have X-ray control, it's very difficult to really judge a diseased segment from a non-symptomatic segment, because all patients have bony stenosis in all levels. Okay, so this is very important, and this might lead to semi-sitting positions in some patients, because you really, I think you should try to get a lateral X-ray for verification of the right level. You could do AP as well, but AP is not that easy if you really want to exactly expose the level. It's a little bit different. If you don't have a straight approach, this is a matter of discussion. Particularly the smaller approach you use a tube system, and you have angulation of the system. It's very difficult because exposure of the nerve root. You think you're right on top of the nerve root, but sometimes you're more cranial, more caudal. And in AP, this will look like almost at the wrong level. AP is even more difficult than lateral. You play with the angles, yeah, I agree with you. It's possible, but there's so many mistakes done, and AP is more difficult to interpret than lateral. I mean, would you agree with that? I think AP correct positioning is more difficult than lateral, particularly if you have 6, 7, 7, 1. It's not that easy. Okay, so this is now the positioning. I really strongly recommend to do a straight down approach. If you don't go straight down, if you have an acculation here, already you will approach the nerve. It will not be right at the level of the facade. It will be a little bit cranial, a little bit caudal. And you think that you decompressed everything, and at the end, actually, there's only the upper 1/3 of the canal you decompress. So it's, I think, important to have a straight approach down. And then it's important to really start, I think, from medial to lateral. Start lateral. Why don't start lateral? Because this is an area when you have a severe cervical foraminal stenosis, there's just 2 millimeters left or something. And if you start lateral, you might really sacrifice the root and you will not notice. You will notice at the end of the procedure when you come medial that you already have dissected the root. So you start medial, you expose the lateral border of the spinal canal, the dural vertebral sac, and then you see the exit of the root, then you go lateral. It's much easier this way. This is a typical result. I think it's nice to do this in 3 levels. You really have a nice exposure, far lateral on decompression of the nerve root, and it's easy, just drilling and then use the Carrison punch. I prefer personally to drill everything with a diamond burr and then the remaining bone flap to remove the Carrison punch, because as soon as you open the foramen, you have the risk, or you have some bleeding. Frequently, you always have some bleeding. If you don't have venous bleeding, probably you're not at the right position. You're not at the right target. Either you're still in the facade, or you're still. If you have to see the veins around the nerve root. If they are not there, probably it's not the nerve root you're dealing with. And this can be done with a very nice cosmetic results if you use one of these systems. So I just briefly show you our data. It's not this or only bony stenosis. And you see that we have most of them done with a medium-sized worksheet, some small worksheet. There was no emergency stopping, no CSF leaks, no nerve root injury. I have to be honest, this is a series from Homburg where I work now. When we started this procedure, and I was not aware that there can be so many easy mistakes can be made that we had 2 or 3 cases in Mainz when I was in Mainz between 2008 and 2010. We had to interrupt the procedure because the venous bleeding was so tremendous that you could not control the intraoperative situation to achieve a sufficient nerve decompression. There was one bleeding surgery to post-op bleeding, and this is the results with a pain reduction. You see, it's a very, 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 very nice, very satisfactory procedure. Those patients, they have a clear radicular symptoms, bony stenosis in the cervical spine. They do very, very well, really. So it's almost 100% without previous surgery, 90% post-operative significant pain reduction with previous surgery. And you see paresis, there was a 100% recovery rate without previous surgery, 75 or 73% in patients with previous surgery. A little bit less successful patients who had already several procedures in the cervical, which is, I think, easy to understand. And the clinical success rate is 95%, the neck disability index very low. So I think it's a very, very successful procedure. So when we conclude, this is a nice tool. I think the posterior foraminectomy should be applied whenever it's possible. It makes sense to do this. It's a good option. The smaller the approach is, and I think it's a very nice indication for an endoscopic approach. The smaller the approach is, the less post-op discomfort and pain these patients will have. And so I think it's a very good thing. So if you have any doubts, and someone left already, that's bad. Because I have shown you a little bit of our experience. If you feel comfortable with endoscopy, you might think you swing from one tree to another like a young monkey. You're here. If you are not confident with an endoscopic procedure, then this might happen. And you recognize this man, and you recognize this man. And then, if you're not sure, you should not hesitate to call somebody either who knows how to do it, or you switch to an open procedure. Thank you very much. Just one last slide. This is the hospital where I work at, and these are the courses we offer. There's also one spinal column society course in May this year. And I just want to point out the International Society of Neuroendoscopy. We have a Cape Town meeting this November. And I'm on the certificate committee, and whoever is interested to come, just talk to me during this day. Thank you very much.
How many endoscopic coronaries are done, and how do you compare the short and long-term result regarding the neck pain? If you compare with the open ones, do you feel any difference?
The long term probably is not different. I have not done this, but long term is probably not different. I mean, what we have is, if you have like huge, we will have a lot of long, distant cervical stenosis. So like 2 or 3 levels, and if I do a vertebral body replacement anterior for minimum two vertebral bodies, I do always combine it with posterior fusion. So I can tell you that these patients, they suffer from some neck pain. But just for aminotomy patients, probably long-term is no difference. Since we don't do those microsurgically anymore, very few, I have no experience more recently. But long-term, I think it's no different.
Then why would you prefer the endoscopic?
Oh, really? Because they are immediately, they are much better after surgery, really. Try this. And this is a real, I think we can discuss about anything in lumbar and everything, but this is really significant. They basically have no post-op pain. And this is really different. If you go through, I mean, you see the neck muscles. And if you go through them and you have to push them aside, they all have significant neck pain. And these patients, they really do much better.
The short-term pain is
short-term pain, let's say up to 3 months or something, is way better. You don't have to put them on excess physical therapy and this thing. Yeah. I mean, there's no doubt that those are subtle advantages. I know first rule is you have to sufficient decompression of the nerve root. If you don't achieve the surgical goal, there's no help of any, endoscope, microscope, whatever. Electrophysiology, it doesn't help, So if you achieve the first goal, then you can talk about some subtle other things.
Thank you.
Thank you very much.